Hello, hello. Oh, I've still got some of the guides up. Let's fix that up here. My name is Gain Treble and it is Wednesday. That of course means we are here for some exam preparation, getting everyone ready for the 2025.1 KFP exam with RACGP. I'm wearing my Christmas scrubs. Oh man, we're off to a great start tonight. I'm wearing my Christmas scrubs. We are a few weeks before Christmas. Hopefully you're taking some time off to spend time with your family, recharge those emotional batteries, maybe even have a break from study, dare I say, and are enjoying life generally. Now, of course, we are all here for some exam preparation, and tonight, if we bring this up, we are 38 days to the 2025.1 KFP exam. So I thought, what a perfect opportunity to have a look at some of the exam feedback and have an approach. Because you can see here tonight, let's look behind me, place is a mess. And sometimes life is a mess, and that's okay. Sometimes you're going to hit one of those questions where you just think, I have no idea. I have no idea what I'm doing. I have no idea what the answer is. How do we take a breath? How do we position ourselves in a way to try and get as many marks from those questions as possible? If we look at the feedback for the exam from RACGP, there's a couple of topics that they say again and again come up, and they're easy ways to lose marks and easy ways to try and string together some marks if you can. Of course, one of the most important things is trying to avoid just repeating information that's already given in the question stem. That's information that's kind of a given, so try not to just feed that back. Try and specify unique management actions if existing measures are already mentioned in the stem. Again, a bit of a duplication there, but it's about avoiding repeating things that are already done. Tailor your answers to the specific question being asked to maximize those marks. So really try and read the question, work out how does this apply to that specific patient in the stem. And of course, try and avoid using the same response across multiple questions in the same case. Now, there's going to be times where you feel like the same answer could fit in multiple sections. And if that's the case, go back and have a look. Where does this answer really sit? Where is the most appropriate spot for it? And that then gives you the opportunity to have an extra free answer slot free for one of the questions that you can fill in with something else. It's about diversifying your answer spread. Now, if you are lost and you're not sure where to go, try and have a few fallback approaches to take that will get you out of jail. So some of the kind of structured approaches to take for this, for our diagnosis questions, try and break things down into that acute, subacute, and chronic class of management. If you can try and think of one or two things that would fall into each of these categories, you're probably going to be able to wrangle some marks out from there. And likewise for management questions, particularly for sticking for acute questions we've mentioned in here before, really try and take that DRS ABCDE framework. Of course, that's checking for dangers, checking for response, sending for help, airway, breathing, circulation, disability, and exposure. Always, always, always expose the patient. If you don't look, you don't find. Of course, then some of those extra ones that kind of get forgotten, the F and G that often fall off there. If it's a surgical patient, you can always specify something like fast the patient. It's one of those little things that seems like silly. Of course you would do that. There could be free marks in the exam. And of course, don't ever forget the glucose. We have it drilled into us time and time again, but it's something that's easy to forget because, again, it's one of those things you just presume it gets done along the way. Slipping across to our chronic management then, the vitamins A, B, C, D, E framework is a fantastic way to kind of fall back there. For chronic management, look at our pharmacological options, which, don't forget, not only includes medications, but also our immunisations. So it's an easy one to kind of sneak a few immunisations in if they're asking for those pharmacological chronic disease management options. For our non-pharma stuff, this is where SNAP stuff comes into play. So make sure you are very familiar with the SNAP framework. Read up the RACGP website summary on SNAP. It is brilliant. And you will be surprised how many times content from that page manages to find its way in the exam. Have a think through all of your allied health referrals. Think of all the different allied health specialties that you could be involving here, whether it's physiotherapy, occupational therapy, speech pathology, dietitians, you name it, they're all fair game. And of course, our other support services as well. So we may have things like allied health assistants or liaison officers that you can engage with to meet that specific patient's needs. Now, if you haven't heard of vitamins A, B, C, D, E before, it is a really good kind of catch-all. Everything will fall into some category. And so if you're drawing blanks on what to put, this is a good little way to kind of think through, okay, are we covering this aspect of medicine? So vascular, infective, trauma, autoimmune, metabolic, idiopathic, sometimes it's us. Neoplasia, social, alcohol or substances. Behavioral, sometimes it's them. Congenital, degenerative, sometimes it's time. And of course, endocrine. Everybody hates endocrine. Another fallback kind of thing for just kind of broader overall management of patients, taking that kind of holistic approach, is the biopsychosocial legal. Never forget the legal aspect as well. And sadly, it's becoming a bigger part of our work day to day. So the biological is to assess those anatomical, physiological processes and where we can potentially intervene. Our psychological is looking into our mental health aspects. Don't forget to integrate different screening tools. If you're aware of some that might be specific to that case, throw them in, as well as considering specialist referrals as appropriate. Social is looking at things like income support, considering those Centrelink referrals as well as Centrelink certificates or medical certificates. As well as just practical assistance. If you've got that kind of general good advice, throw it in. And legal, everyone's favourite legal. Legal advice can be from a lawyer, so consider bringing them in. Medical indemnity providers, covering your own backside, as well as patient directives. So things like referring them to police to make statements certainly fall into that bracket there. Now, there's also the 5A's approach, and this is pretty much guaranteed to be on the exam in some way, shape or form in some question. It's about ask, so identify key issues, advise for clear guidance, assess, so evaluating their readiness for change as well as their capacity, assisting, so offering practical support to implement those changes, and of course the follow-up, arrange, so plan that follow-up or additional interventions as required. Of course, here tonight, we are here to arrange some practice questions. That was possibly the worst segue I think I've ever done for this. But we have 3 cases prepared, and I'm really keen to let you practice these questions. If you want to throw your answers into the chat, we can go through them and have a look what might be fantastic answers, what might need a little bit of massaging, and what might be incorrect, and we can potentially steer you into the right direction. So, of course, with questions, let's put 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some of those answers. So this is one of those cases where either you know it or you don't know it. And I kind of threw this one in here, given we're just covering this kind of topic. Now, I've tried to make it also a little bit obvious, shall we say, so it's not going to scare too many people away. Of course, this is digoxin toxicity, and sure, early in the stem it kind of throws out, oh, by the way, he takes digoxin. Always listen to those little hints they're trying to throw in. So we've got multiple hints in here. So we've got the nausea and fatigue, which is very common, particularly in early manifestations of digoxin toxicity due to the effects on the gastrointestinal system. We've got that intermittent confusion as well, which is the neurological toxicity of digoxin. You often get associated drowsiness and sometimes even hallucinations if it progresses far enough. We have our visual disturbances, which also includes that. The classic finding here is that yellow halo around things, sometimes green halos, or sometimes just subtle blurred vision. And of course, we have skipped forward. There we go. Let's go back. And of course, we also have here the basal lung crackles, which this one's a little bit more subtle, but you can see with the direct cardiac toxicity, a more cardiotoxic profile and pulmonary congestion due to that heart failure. Now, if you're going to just kind of guess around a little bit, you'd still get some marks for guessing things like congestive cardiac failure or acute on chronic kidney disease. But you're not going to be ticking that big box there. It's going to get you 3 marks as opposed to the others being only worth 1. Now, let's have a look as well at what our next question is. We'll put another 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some of those answers. And here we have to really pay attention to what is the actual qualifier in this question. So what is the most appropriate initial investigations to confirm the diagnosis? So a lot of these things you would do in a patient with digoxin toxicity, but what's the very first most important things you're going to do to really lock in, confirm that diagnosis and know what you're treating? Obviously, a serum digoxin level is going to come in pretty handy to do that, so definitely going to get marks for that one. Our renal function tests, so urea, creatinine, EGFR, yes, in practice, we're going to do those alongside things like our electrolytes, so there's a bit of overlap with F, but in the exam, you should be knowing which components of which tests you're looking for in particular, so sometimes expect to see these split up like this. So obviously the renal function test is going to be assessing our renal clearance, which is going to be a really important factor when assessing digoxin toxicity and has implications in terms of why this may have happened in the first place. Now, of course, serum potassium level is also going to be incredibly important because we're going to be looking at hypo or hyperkalemia, which can both come into play with digoxin toxicity as well as our overall cardiac function. Next up here, we have our chest x-ray. So while it's not specific to digoxin toxicity, it is actually a really valuable tool for excluding a lot of the other potential causes that we could be looking here. So would definitely be a very valuable first investigation, particularly when we have some of those chest findings there with the bilateral basal lung crackles. Of course, our 12 lead ECG, let's be honest, one of the main things we're all expecting to see here is those classic ECG changes which would suggest digoxin toxicity, and so while you're waiting for your serum level to come back, you could be grabbing that ECG, confirming the diagnosis straight away. Could that be a hint of things to come, potentially? Let's find out. We've got one more question here. Let's put 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some of the answers here. And for those who may be worried maybe the ECG was a little bit smaller than you would like, imagine what it's like when it's printed out on paper in the exam. Often they don't have the greatest scans available, so get used to practicing with perhaps sub-quality printouts. I think, though, for those that know what they're looking for here, and hopefully you guys do, there are lots of very obvious findings here. Probably the most famous thing we're looking for, and the thing that's very well pointed out here, is this sloping of our ST segments. And then coming up, this is that slurring ST or Salvador Dali moustache sign. And for those of you who know who Salvador Dali is, yep, we're getting old. If you don't know, Google it quickly, you'll see it'll make a lot of sense. We also, of course, have our inverted or biphasic or flattened T waves. If you're putting any of those, all of those things can happen, often seen in multiple leads. And this is due to the digoxin toxicity. Here we've got a kind of combination of each of those findings, depending on which lead you're looking at. We also classically have our PR interval prolongation. This one, very difficult to see, admittedly. There are a couple of little hidden P waves around the place. That if you're really paying attention, you will see them. Of course, we do know that things like atrial fibrillation are going to be associated with digoxin toxicity, which is why also if you are putting that, you're still going to get a mark. And there's arguably AF in this ECG here. There is that little bit of irregularity as well, but there are a few also hidden P waves that kind of steer away from that a little bit. We'll also see things like J-point depression. You don't quite hit that isoelectric line before going into your ST segments. And with that, you'll also see atrial fibrillation, as we've already mentioned there. Now, bradycardia for this question wouldn't actually get you a mark, even though it is one of the common findings with digoxin toxicity. Yes, if we look at the stem, they have 48 beats per minute. But if you actually count out this ECG, and what it's asking you is about this ECG in particular, this heart rate's much faster than that. We're in the kind of 90s odd. And so you wouldn't be getting a mark for the bradycardia mark there. And while we often see PVCs associated with this condition, we're not seeing any here. And so again, wouldn't get to those marks. How'd you go? Hopefully you've scored a few points in that one. If in doubt, try and think back to what the diagnosis is and just kind of regurgitate all the things you know about that. Again, bearing in mind that you may not necessarily get the marks in there, even if you're not entirely sure if what you're seeing is actually what you would expect to see. All right, now we do have 2 other cases for tonight. Let's load them up here. And of course, case 2, question 1. Let's get 2 minutes on the clock. Your time starts now. All right, time is up. Let's have a look at some answers here. Wow, there's a lot to choose from. Now, of course, we all have patients like Brian. Brian that comes in with one thing and you think, oh, this is going to be a long consult. And then they bring up another thing and you think, oh, there goes the day. And then they bring up another thing and you think, I want to go home now. So let's tackle one problem at a time. What aspects should be elicited for his lower urinary tract symptoms? This is really about knowing what to take for a urological history. What are the key symptoms that you want to be aware of? So lots and lots of choices here. Of course, the ones that are going to be more directly related to more sinister things are going to give you extra marks. For this, the main ones are going to be, have you noticed any blood in your urine? 2 marks. And is there any family history of prostate cancer? Really, that could be extended out to any kind of urothelial cancer. It's acknowledging what is your personal cancer risk in this circumstance. Now, of course, this case in particular is starting to bring up things like prostate cancer, and so that's why we kind of default to that one there and use those hints in the stems to give you those marks. Of course, do you experience any difficulty initiating urine? 1 mark. Do you feel your bladder is not completely emptied after urinating? Another one. How many times do you wake up at night to urinate? So assessing for nocturia. Do you ever experience urgency? Do you ever experience incontinence? Do you ever experience a weak or interrupted urine stream? In the actual exam, I would not be using the or qualifier. We'd be specifying one or the other, or the, you know what I'm trying to say. And of course, how often do you feel the need to urinate through the day? So there may be some people who get a little bit nervous about having one question about how often do you go at night and one how do you go through the day. You could look at combining something like that by saying what is the pattern of urination over 24 hours, but they do assess different things, and so I still think you would actually get different marks, and in this circumstance I don't think you would actually get them in grouping. Of course, we have lots of other options to be choosing, and so I would try to diversify those answers as much as possible. Moving on, of course, do you ever feel a strong sudden urge to urinate that is difficult to control? This is actually, again, a subtle but different thing from urgency. And have you ever experienced any pain/burning sensation during urination? Are you using one or the other? I wouldn't be using both. And has your urinary pattern changed recently? So not just what is your usual pattern, but has there been something in particular that's different that's actually prompted this presentation? Now, of course, he had lots of problems. So let's put 2 minutes on the clock. For the next question, your time starts now. All right, time is up. Let's get to those answers. Now, if you are not intimately familiar with the RACGP PSA screening page, go there now, maybe after this, and read it, memorize it. It is something that you should be reflecting on and using day to day because this is a very common situation. So, first thing first, discuss that the national population screening for prostate cancer is not recommended in Australia. Definitely 2 marks there. This is not something that should be done routinely, and extensive counselling should occur before just sending off for a PSA. Of course, next important bit here is that to reinforce that the benefits of PSA testing can include early detection of significant prostate cancer, which might improve outcomes. And the big qualifier there is the might. Of course, there's a lot more that goes into that conversation, but for purposes of trying to answer this question, that's the kind of phrasing you're wanting to look at. Yeah, it's a bit long and a bit wordy, but something along those lines is going to get you 2 marks. Now, for this next bit, there's a few things that you could mention. So I've put the slashes there. They would all be grouped as one kind of mark. You wouldn't be putting this multiple times. So the potential harms of testing include overdiagnosis or unnecessary biopsies or treatment of cancers that may not cause symptoms in the patient's lifetime. Prostate cancer is one of those cancers that a lot of people will die with, not of. And that's where looking at the patient's age in particular circumstances really comes into play. Now, in men aged over 70, the harms of PSA testing generally outweigh the benefits due to the lower likelihood of meaningful mortality reduction. This is one of those things where there's actually that table that I have printed at my desk and use for all of these discussions to show what are the actual risks and benefits. Now, as has been very appropriately pointed out in the chat here, in this case, it is still screening given Brian is symptomatic, is it? Thanks. So, yes. because at this point in time we have urinary frequency, weak urine stream, and nocturia. So we have a few symptoms in there, but I think without eliciting more history, we can't say that we think this is prostate cancer. And probably the first test you would do for a patient like this is going to be urine MCS and exclude infection. I don't know if I'd necessarily be jumping straight to a PSA because, of course, one of the things that will throw off a PSA level is infection, which can falsely elevate and, again, kind of lead you down this wrong pathway. So if I'm actually talking about it and discussing, are we going to send that off? All of these things still very much come into play, and you would probably have that reflection of, look, lots of other things can falsely elevate it, and so that is something we would have to take into consideration. Hopefully that answers your point there. Now, of course, Brian here is having a rough time. He has more things he wants help with. So let's get 2 minutes on the clock, and your time starts now. All right, time is up. Let's have a look at some answers and prepare yourself because there's a few. Now, this is where we should be looking at what are our common mental health conditions and, importantly, what are their actual clinical diagnostic criteria. So most people will switch to DSM when it comes to mental health conditions, and so we should actually be knowing relatively well what are those clinical markers that we have to be meeting to actually make an actual clinical diagnosis. For this, the key things as per DSM-5 text provision is that the death must be at least 12 months ago of a person who was close to the bereaved individual, 2 marks, and that since the death, the development of a persistent symptom of, and you can choose which one you like the most here. We've got intense yearning or longing for the deceased person, preoccupation with memories, identity disruption since the death, a marked sense of disbelief about the death, avoidance of reminders of the person dead, intense emotional pain related to the death, difficulty reintegrating into one's relationships, activities after the death, emotional numbness as a result of the death, feeling that life is meaningless as a result of the death, intense loneliness as a result of the death, and the disturbance causes clinically significant distress/impairment in social or occupational or other important areas of functioning. Lots of potential targets, and even if you're kind of guessing and applying some common sense, you're probably going to be getting some marks from here. Of course, we should be knowing what our diagnostic criteria are, and I would actually make a list of the common things we see and try and marry these up. Of course, there are still more criteria here. Now, for our time markers here, the duration of severity of the bereavement reaction clearly exceeds expected social, cultural, or religious norms for the individual's culture and context. So really important that we actually tie together what is normal for that patient. Often mental health diagnoses have specific time criteria. And I actually quite like this diagnostic criteria because it does factor in what is actually considered to be normal for that patient, for their background, because that's going to vary wildly from culture to culture. Now, of course, symptoms must be present for most days to a clinically significant degree. Symptoms must have occurred nearly every day for at least the last month. And the symptoms are not better explained by another mental health disorder or substance use or medical condition. If you ever get stuck in these mental health questions, that last point is essentially free marks. You can pretty much always put that the symptoms are not better explained by another cause, and you'll get marks there. Are you going to get as many marks as you would for other responses? No. But if you get stuck, get out of jail free card. Okay, now hopefully you've done well with that. Of course, we've got one last case for tonight, so let's get 2 minutes on the clock. Your time starts now. All right, time is up. Let's have a look at some answers. This is one of those really horrible conditions that I really hope none of you ever have to go through. But unfortunately, doctors all across Australia face this kind of thing every single day. The most important thing in this response, in this case, in this situation, is safety. And so the thing that's worth the most marks, as it should be, is to excuse herself or get herself out of there for consultation if she feels unsafe, and to seek immediate assistance from a colleague or practice manager. Yes, this one's a little bit wordy, and you do risk a bit of overcoding from that and seek assistance. You could specify to seek assistance if you're worried about wording there, but it's about getting yourself out and getting yourself back to a safe situation. Now, if you're in this situation and you are feeling like you are safe and able to intervene, then of course it's really important to clearly or firmly state that the behaviour is inappropriate. Call it out for what it is, to clearly and firmly request that the behaviour stop, to warn Mr. Baxter that the consultation will be terminated if the behaviour continues, to warn him that his care may be discontinued with the practice if the behaviour continues. So subtly different, but different enough that you won't fall into grouping for this, because one's about interactions with one individual GP and one's about the practice as a whole. Of course, document the incident thoroughly, including details of what occurred or how it was addressed or any witnesses present, as long as you're covering some element of documentation there. Consider discussing with police if you feel there is sufficient material or concern or worry to do so. And of course, discuss with your medical indemnity provider as well. That's about covering your own backside and making sure that you're as legally protected as possible. Now, these responses here come from the Responding to Sexual Harassment by Patients Guide from RACGP. If you go to the RACGP website, there is a whole section there about running a practice. It is all fair game for the exam as well. And so you should be familiar, even just passingly familiar, read through each of these resources because you may find questions such as this in the actual exam as well. Of course, we have another question here. Let's get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at some of the answers here. Now, this question's in here not only because it's fair game for the exam, but also because I want you to be thinking about in your day-to-day practice, is this something that could happen to me? And are there things we could be doing ahead of time to minimize that risk to myself, to my colleagues, to all the staff in the practice? So there's a heap of things that we can and should be doing day to day. And some of the things are things you might not even realize. So lots of answers to run through. Of course, number one is going to be not disclosing personal or staff details to patients because you never quite know what their agenda is. And you may feel this is putting a barrier into rapport building, but it's actually an important part of actually protecting yourself and the staff of the clinic from people who may have their own agendas. Of course, number two is to have a zero tolerance policy on sexual harassment by patients. And this should be advertised to patients through things like posters in the waiting area or signs at check-in. There should also be a process of building a safety culture within the practice team. So having ways to flag when people feel unsafe or designated people they can go to should an event occur. There should be consultation with the team on safety concerns or potential initiatives. People may have individual needs or requirements that are important to meet, and the only way to find those out is to ask. We should ensure that staff feel safe to report sexual harassment by patients to their practice manager or supervisors. So again, this could be having policies or pathways in place to help people navigate who should they be speaking to when these things happen. To regularly assess your your practice's risks, considering your patient demographics, cohort, or the physical environment in which you practice. There should be clear definitions of what kind of acts or behaviours require a response. So instant kind of triggers to say, if this happens, then this is how we should reply to it. And again, they can also be advertised to patients through posters or materials so that people also know, hey, we're not going to tolerate it, and this is the action you can expect if it is found to be the case. This could be considering the design and layout of your practice and consultation rooms. We'll come back to this one a little bit. There's another answer that does double up a little bit. There's potentially grouping there, but it's all about making sure there's things there to actually maintain good patient safety, good patient flow, good practitioner safety and practitioner flow in the event of an emergency. A big part of this then is installing a duress alarm or phone alert system that your practice can use if a patient is either threatening or violent. There should be also tied into that a response plan for when those alarms are triggered. So it's not just people kind of poking their head out saying, oh, is everyone okay? There should be a designated response that everyone knows what to do at the time. And it may be as simple as everyone runs to that room. Of course, we should consider the appropriateness of things like closed circuit television. This is something that I think would really be dependent on the risk at your practice. So again, this is kind of based off the patient cohort and the physical environment, as well as taking into consideration the area immediately around the practice as well. Bearing in mind, if you do put up things like closed circuit TVs or monitors, there are legal requirements state-based that you would have to look into and certain signs that would have to be placed to notify patients this is the case. And there's potentially going to be limitations on where they can actually be placed within the practice. Now, next part sounds stupid, but this is a situation I myself had unfortunately found myself in at one point, was ensure that no team member is alone on premises at any time. You might think you're doing someone a favour by opening the practice on a weekend and seeing them one-to-one. You may be setting yourself up for a bad time, so always be mindful of that and make sure the practice is a way to make sure those kinds of situations don't occur. Ensure that outside areas are well lit. This is particularly important in winter or in locations where it gets darker earlier. It's again just maintaining that safe environment, and of course conducting thorough team member inductions with regular training on the practice's incident response procedures. So making sure as new people come in, they're actually trained and know what to be doing for these things. Whew, it's a fair few things, hey. Of course, this is asking for 4 responses. And we've got a lot more things here that we could be choosing, and this is a good reflection that often for the exams there's going to be multiple answers that we could be providing. All right, we have one more question for tonight. Thank you everyone for sticking through so far. Let's get 2 minutes on the clock and your time starts now. All right, time is up. Let's have a look at some answers. You all probably thought it would be a nice, relaxing evening doing a couple of practice questions. Sorry, it's been a bit full on with these ones. Of course, we do need to know, and yes, it's definitely fair game in the actual exam, to know what are APRA mandatory reporting triggers. And so the key ones to be aware of here is practicing with an impairment, with the caveat that is not being managed by effective controls. And those effective controls can be quite broad. Can be a treatment to break from practice, like sick leave. Can be a modified scope of practice or supervision. Can be strategies to manage the impact of that impairment, working in with the workplace, monitoring or supervision we mentioned before. And of course, one that I'm always a bit weird on is a reasonable belief that APRA has already been notified. So if an APRA report's already in place and you see something, apparently you don't need to tell APRA. Go figure. Now, of course, practicing while intoxicated, this could be alcohol or drugs, a massive no-no. And again, I want to flag here because it is sadly a very common thing for doctors to turn to with the inherent stresses and nature of our job, is substances to de-stress and take away some of that stuff in their life. It's not a solution. Please, if you think you're falling into that kind of category or you know someone that is, get help, put the hand up and sort it out before it becomes a problem. Now, you can also be practicing in a way that significantly departs from accepted professional standards. So if you see someone who's doing something that is completely off the charts, ivermectin, that may warrant a mandatory APRA report, and of course engaging in or having previously engaged in or being at risk of engaging in, I'm not sure how they flag that one, sexual misconduct in connection with their practice of medicine. So no relationships with patients and no relationships that are going to be impacting on your practice of medicine as well, mandatory reporting. Lots of things to go there, and again, we've got more potential answers here than are requested, and you'll find that's generally the case across a lot of the KFP questions. Well done, you've made it through. It is the end of the cases for tonight. Hopefully you have found this helpful, and of course, if you have, feel free to pass the message on. We're here to help as many people as possible. No one gets left behind, so do spread the word. I'll hang around in the chat for a couple of minutes if anyone does want to ask any questions. Otherwise, thank you very much for your time tonight. They did get a little bit heavy, shall we say, particularly as the night went on. But I wanted to use tonight to flag some of the things that, you know, I wish perhaps some people had said to me during my training, to see if tonight has flagged a few things for you that have you concerned or have you thinking. Have a chat to your supervisors, have a chat to your practice manager and see if there's things you could put in place to actually make everyone in the practice's lives better. Ultimately, that's what we're all here to do. Try and help people, try and help ourselves. On that cheery note, let's call it for tonight then. Again, I'll hang around in the chat, so if you do want to throw anything in there, go for it. Otherwise, have a great night, have a good sleep. Counting down for Christmas, I'll be doing one more live stream next week. And I might have Christmas Day off. I hope you don't mind. But we will jump back on. I will probably do the Thursday night the week after. That'll be the 2nd. Give you a night to celebrate New Year's. You may be feeling under the weather otherwise. And I will look forward to catching you all then. Ho, ho, ho. See you guys.